Good morning, everyone. And it's an honor to be here and invited to be a speaker at the eighth annual World Health CME. Okay, need to be over here? Oh, I could talk loud now. Okay. Okay. So, just 1 second. So my presentation will be on patient engagement and cultural competence, a roadmap to achieving health equity. So just the slides. Yeah. Yeah, that's what I was doing. Yeah. Okay. So I have no financial disclosure. And so my presentation, let's look at it from what's the purpose and the objective. So the purpose is to present strategies to enhance empathy, respect for cultural beliefs, and equitable care delivery, with a particular focus on improving the outcomes for individuals with sickle cell disease and the elderly Black population. And the objective is to increase empathy, respect and understand individuals' cultural beliefs regarding their health, prevent judgmental behavior directed at patients, prevent disparate care, maintain patient dignity, and improve the health outcomes for a diverse patient population with a focus on the elderly Black population. So, in terms of the agenda, we're going to talk about the overview of the session, the purpose and the objective. We're going to explore cultural beliefs and attitudes, examine the role of language in medical documentation, discuss the significance of the why question in patient care and the perception reality, share strategies to enhance cultural competence among healthcare professionals to better provide responsive and respectful care. And going to do a case study at a patient at Kings County, and to summarize key takeaways, and then question and answer, and closing remarks, and the CME credit questions. So who are we? Who am I? And, so I don't know if I need to go over all this, but I'm an accomplished physician for over 20 years. I pioneered the key initiatives at New York City Health and Hospitals, such as care management program focused on sickle cell disease, and the first sickle cell support group I started, and drove significant reductions in congestive heart failure readmission at Kings County Hospital. I developed patient engagement and cultural competence training program that has been widely accepted at Khalida Health, Northwell, Toro Medical College, and recently at Morehouse Medical College as well. I'm a fellow of the New York Academy of Medicine, and I received Excellence in Medicine Award from the Bronx County Medical Society in 2021. And I presented at prominent meetings and published several peer-reviewed articles. My book, 9 Simple Solutions to Achieve Health Equity, a guide for healthcare professionals and patients, was published on June 19, 2024. And by the way, it was my birthday. And it's #1 bestseller in the new release category on Amazon, and #4 in health. So we're going to identify our cultural beliefs and attitudes. So what do we as individuals in this room value? We value self, family, work, integrity, religious, cultural, and ethnicity, finance, health, fun and recreation, privacy, dignity and respect, and choices. And you'll see choices is in red, and I'll explain that shortly. So are patients really different than ourselves? I would assume the patients value the same things we value, including choices. So when the negative language in the medical records, I'm going to address in a moment. So when you say choices, so let me ask the question, what is the similarity between a homeless person and a millionaire? Does anybody could think of a similarity? Huh? Could be. So when I do presentations, most of the time the answer I get, well, only thing I could think about is that they're both men. I said, there could be women too, but that's another story. So what is the common thread? Once accurately diagnosed, there's no human being on planet Earth can give it back. The millionaire can't say, I'll give you $1 million to take the cancer back. Oh, that's not enough, I'll give you $5 million. In life, we have choices, and this is the only time that there's a non-negotiable that serves and recognizes all human beings, irrespective of race, gender, ethnicity, social economic status, country of origin. And so maybe health systems could be more empathetic and less judgmental, and to recognize the bulk of us taking care of patients never laid in a hospital bed. And those that do are women delivering life, and in some cases, patients may be trying to prevent death. And so with that background, when you look at now negativity in the medical record, how many times have you heard the word non-compliant? Raise your hands. Oh, and there's a nicer word, non-adherent. Yeah. How many times have you heard the associated why question? So isn't that kind of interesting? So we don't know why John Brown didn't take the medication, but we're going to refill the same prescription he didn't take and don't ask why. And then if he doesn't follow directions, you're going to have non-compliant, non-adherent. You know, if it's written in the medical records 2 or 3 times, that patient is under the help bus. Who's going to care about that person? Because everything is his or her fault. In other words, frequent flyer, no longer human. Anybody know who came up with that term, frequent flyer? High utilizer, game in the system, and deserving of punishment. Drug seekers, oh my God, for patients with sickle cell, how many times have you heard that? Okay? And it's an unfair characterization of patients with sickle cell disease. And when you have these negative language terms, it creates a culture of callous disregard and possibly contributes to poor health outcomes. So counterproductive thought process. Documentations that I mentioned rarely mentions the why. Physicians and nurses, we are trained to ask why, right? God forbid we don't ask why the fever, why the headache, why the abdominal pain, why? But when it comes to asking the patient, why didn't you do something? So I'll give you an examples of this particular true story when I was at Kings County in charge of the congestive heart failure readmission prevention. 60-year-old African-American male recently diagnosed with congestive heart failure, returns 2 weeks later, congestive heart failure decompensated due to non-compliance. So when that person goes up to the unit, you think anybody's going to care about that person? I don't care what hospital. And one of the nurses down the hall says, so he just got diagnosed with a life-threatening condition and don't follow directions. I got other things to do. My team had to ask why. Why? Because they said, if you don't ask why, they used to call me Dr. B. Dr. B is going to bug out, you know. So I asked, why didn't you take your medication? And I'm glad you're all sitting down. Why can't you take your medication? I can't take the water pill. Why can't you take the water pill? Because I drive the number 7 train. So when is your shift? 11 p.m. to 11 a.m. What do you do when you get home? I do some chores, I take some of my medication, but if I'm going on my shift, I don't take the water pill. The same cardiologist who was ignoring him, I brought him in, and that's why I think systems could change. He said, take the water pill when you get home. Be aware it may wake you up during the day, but by the time you get to your shift, you'll have less of a reason to urinate. But to the degree that you do, we're going to give you a cubicle so you could use in a private space when the train stops. And you know what the patient said? If I knew I had to choose between peeing and breathing, I would have chosen breathing, you know. And I said, expand the conversation. You know, he would have been readmitted multiple times, right? And then they would have called him frequent flyer. And then if it were, and you know he was going to die. There's no question about it. And at mortality, it would have said died due to non-compliance. It was died due to non-compliance if we didn't ask the why question. And it would have been our fault as opposed to the patient's fault. We were able to save this black man's life so he didn't have to choose between his health, his job, and his life. So the negative language can cause potential adverse health outcomes, cause repetitive emergency room visits, cause increased readmissions, and increase the health burden on patients. So patient responds if you ask the why. If you are a hospital, and I give instructions to patients as well, if you're in the hospital on or a doctor's appointment and you are asked, did you take your medication or did you follow direction? The patient responds, no. Wait a few minutes. If you are not asked the why question, say, do you want to know why I didn't do it? And please don't write non-compliant and non-adherent in my medical records because it can have a negative impact on my health outcome. Could you imagine if patients are now communicating that information to physicians for change in culture? So, eradicating misperception and fallacies, perception versus reality. Because if your perception of me is not my reality, my health is going to go south. But if the perception and reality is the same, good, bad, happy, or sad, we have an opportunity to collaborate with everyone. Perception, reality versus reality. So the COVID pandemic had shed bright light on long-standing numerous health inequities experienced by Black Americans across the U.S. The Black population had the highest COVID death rates. Perception, the prevailing thought that it was a result of poverty, lack of access to care, social determinants of health, and comorbidity. The reality actually is that Prince George County, in Maryland, right outside of D.C., one of the wealthiest Black upper-class communities in the nation, and they had the highest COVID mortality. Brooklyn, New York, has a significant Black population, is home to at least 13 hospitals, including 3 public hospitals, 1 state hospital, extensive public transportation, and they had the highest COVID-19 death rates in New York City. It was in Brooklyn. The public transportation employees who died were predominantly Black, who were union workers with an average salary of approximately $50,000, and they had pensions and they had health coverage. And probably the reason why the bulk of the patients, the bulk of the employees died, because at that time we were just learning about COVID. And the bulk of the people that work on the subway system and train transportation are Black. You know, so we have to put things in the reality of the situation. It's all contributory. So let's look at the myth of patients with sickle cell. Sickle cells have a higher degree of drug addiction than the general population. The fact is, opioid addiction for sickle cell patients ranges from 0.5 to 8% versus 3.0 to 16% in patients with other chronic pain syndrome. And I created the first sickle cell support group, and these are just some of the statements from patients. Could you imagine when a patient who is about in his 18 or 19, I have a 50% chance when I'm admitted to a hospital, someone will be nice to me. This is from the patient's own words. And the pain is like a sledgehammer, constantly hitting me up and down my spine. When I'm in crisis, the pain is so severe that I really want to die. When I'm at home and feeling better, these thoughts go away. Yes, I'm a drug seeker. I need drugs to relieve my pain, but I'm not just seeking drugs, okay? And this is a population, their voices and the humanity and who they are as human beings is not discussed. And to recognize the fact that the bulk of patients that with sickle cell and the families, there's no family counseling offered. I really did research on family counseling. When one child has sickle cell and one does not, how does a family cope with it? And there's no family counseling. But these services are offered to patients with cystic fibrosis. And what is the difference? Okay? So the treatment of sickle cell patients, individuals diagnosed with sickle cell, they receive, as I mentioned, a low standard of care. Race does play a role. And the social construct of race in America requires the majority of patients with sickle cell not only to face the consequences of serious health condition, but also to navigate a society in which the color of their skin is often at an unfair disadvantage, which causes them to be labeled drug seeker. And it's been proven in the medical literature, patients come back to the emergency room earlier than, quote, they should. It's not because they were seeking drugs. Guess what the main reason was? They were undertreated the first go-round, okay? And the medical evidence does not support, as I mentioned, the term drug seeker. So the questions and comments of patients that are in the emergency room, and I think I would want to share that with patients. I'm a human being who happens to be African American. I have a life-threatening disorder, sickle cell disease. I'm in severe pain and I need to be valued and treated now. Like you, I have dreams and aspirations, so please do not cut my life short because you don't think you value me. And if there's no response, ask to speak to the ED director. If you didn't have a PCP and you were admitted or you're going to be discharged, ask that you get a hematology consult, because a lot of times they're not offered hematology consult. And so could you imagine a patient and a family member is telling, I'm a human being. Why do I have to now become a human being in order for you to treat me? And I'm sure you have heard the word sickle cell warriors, and everybody think it's cool. That's what patients now of they're warriors. They have to be warriors. So I'm 21 years old or 18, and I'm potentially midway through my life expectancy, and I have to be a warrior. What does it tell you? If I have cystic fibrosis, I don't have to be a cystic fibrosis warrior. If I have leukemia, I don't have to be a warrior. So what is it about being a patient with sickle cell? What does it tell you about a health system when I have to be a warrior and I'm potentially midway through my life expectancy? And so, as I mentioned, ask for behavioral health services and to be able to discuss your fears, anxiety, depression, family, circumstances. Make sure you have a follow-up appointment if you're being discharged. Don't have to feel uncomfortable in requesting mental health counseling, and it should be a vital part of your treatment for sickle cell disease. It should be offered. Patients shouldn't even have to ask for it. We should ask, I want to recommend you to see a therapist or a family member, a family counseling. That should be offered. And recognize the need, as I mentioned before, life-threatening cystic fibrosis, they don't have to do that. Okay, so this is an important statement from Dr. Zemsky, who's a pain specialist in Connecticut. He said, in the words, difficult patients are not just born, they are in part created by their passage through the medical system. Not only the system failed to cure, it may have done unpleasant things to make matters worse. Sorry. Oh, what did I do here? I'm sorry. I'm sorry. I'm not really good at this. Could you come and help me do this? I don't know what I did. I apologize. My kids have given up on me and my computer skills. Yeah. Just go back to keep going, where I came from. Yeah. Go. So. Okay, yes, from Dr. I'm sorry about that. My apologies. And so I tell patients to keep that statement from Dr. Zemke in their phone. And so when they go to the emergency room, show that and say, please don't do unpleasant things to make my condition worse. Thank you. Could you imagine a 21-year-old patient now, black patient, male or female, is now showing medical literature to their doctors in the emergency room? So let's look at cultural competence. Cultural competence is defined as the ability of providers and organizations to effectively deliver healthcare services that meet social, cultural, and linguistic needs of patients. A culturally competent healthcare system can help improve health outcomes and quality of care and can contribute to the elimination of racial and ethnic health disparities. At Kings County, it was a very, very humbling and amazing experience, and my team they did such a great job. And the population, 93% of the population were of African ancestry, 50% of the patients were Caribbean, 36% African Americans, and 4% Hispanic. The patients of non-African ancestry were 3% white and 4% other. And so I was in charge of the congestive heart failure readmission prevention program from 2011 to 2014. And what we realized is that the daily questions that the team had to ask, who is the individual? What are the fear factors? That's another thing that's not covered in healthcare, patient fears. Could you imagine how you could see how patient fears can potentially lead to non-compliance? Okay. What's important to the individual, not what we think should be important to the individual, but what is important to you, as opposed to me telling you what should be important to you. And where is the patient in the acceptance of the disease? Because if I'm planning a vacation for my family and I did a mammogram and it's positive, I may not even know who I am at that point. So this is where the humanity of it all, and for us to recognize the bulk of us taking care of patients never had any of these experiences. And the team philosophy, not to be judgmental, never use the word, as I mentioned, non-compliant without why, improve patient engagement and cultural competency, identify African American, Afro-Caribbean, and recognize the heightened patient value. And the reason I say recognize African American and African Caribbean, Afro-Caribbean, there was an Indian patient in the hospital, in the bed, and the nurse said, "Oh, where in India are you from?" And he got very upset. "I'm not from India. I'm Guyanese. I'm Caribbean," And so that's when I call the lookalike syndrome. And when I do presentations, I say, go tell a British person they're Irish and see how far you get. Go tell a Chinese they're Japanese. Go tell an Indian they're Pakistani. Go tell a Jamaican that they're Trinidadian. Go to the Nigerian that they're Ghanaian, and tell the Puerto Rican that they're Mexico. And most important, listen to me carefully, people. Go tell a New Yorker they're from New Jersey. And that is not going to go over well. And to recognize and heighten patient value. So it's important because of the population, we need to understand where you're from. So the team was interdisciplinary. We had hospitalists, we had patients actually, if they could ambulate, could join the team. We had dietitian, pharmacy, care case managers, social workers. And we were able to decrease the readmission from 30% to 18.7 in less than 2 years. 30% decrease reported by the Kings County Medical Director, and 18.7 decrease. The report came from Medical and Professional Affairs of Central Office at Helton Hospital. And the person who came up with the 18.7 on the team, the clerical associate, was the least educated. And so when you understand, because I'm least educated, that doesn't mean I'm least intelligent. She kept all the data, and when the report came out and I said, "What's the number going to be?" And some people said, maybe 20%, maybe 21, 24. She said, no uncertain term. Dr. B, 18.7. And when the report came out, 18.7. And so when we think about education and intelligence, to recognize the bulk of corporate America, in charge of corporate America, are less educated than the people they hire. So patient voice. 84-year-old African-American female from South Carolina said, "My parents were a step away from slavery and my grandparents were slaves." 82-year-old African-American who stayed on a weekly day, "What I'm most concerned is that I will not be going to church on Sunday." She stopped eating. This was a Wednesday. Stopped taking care of herself, stopped participating. And everybody said, "We need to do depression screening, call psych." Absolutely, that's protocol. But I went in to see her and I said, "Could you tell me what's important to you?" And she said, "The fact that I will not be going to church on Sunday." I said, "Find out what church she goes to and let me speak to the minister." We found out I spoke to the minister. He came in and he prayed with her and told her, "Even if you are not discharged on Sunday, I will come back and pray with you." She was a different woman because she no longer felt guilty of not pleasing God. And to recognize the role of religion in the elderly black population. I don't think there are 3 black women or men across the world that are atheists in that age group. And I say, when a Holocaust survivor comes in the hospital, we roll out the red carpet. The chief medical officer, the board of directors, the CEO, the rabbi will go and see their patient, and so they should, because of the horrific circumstances that they endured. But when an elderly black person who fled the South because of Ku Klux Klan, lynching, and Jim Crow, and the atrocity happened here, how come we don't roll out the red carpet? And they have the worst health outcomes in all disease category. And it's an opportunity to recognize and treat all atrocity survivors the same, and to realize the role of religion in these 2 populations were pivotal to their survival. So who are our patients? Not only are they English-speaking and American-born, but they're also from different countries. They speak several languages and may have different religious beliefs. They may have different expectations regarding the healthcare needs and the role of healthcare providers, and they may have different beliefs about using Western medicine versus herbal medicine and or home remedies. Challenge: not to have the patient choose between health and family, health and culture, health and religious beliefs, health and finance, and health and education. Cultural sensitivity towards foreign-born patients. American clinicians need to understand cultural norms that are different from American norms. The role of, this includes the role of the caregiver. The caregiver may not be the decision maker in other countries, and the role of the clinician in other societies. Example, I say you do philosophy. So we have to understand, how do we understand the cultural norms and what's the expectation from the population we serve. Just in summary, behavioral health starts with healthcare professionals and executives. Professionals and patients share the same human concerns and emotions. Illness trumps religion, ethnicity, race, gender, and culture, and historical trauma can influence patient behavior. Terms such as frequent flyers, non-compliant, non-adherent, used in healthcare setting towards patients can create a culture of callous disregard. A culture of callous disregard can negatively impact patients' health and safety, and thus affect patient compliance. We can all become patients at any given point in time. And just an example, when I did a survey with doctors and nurses, and I said, how many people are taking medications? Everybody raised. How many people are taking 5, 4, 6? No, the top number was 3. There was one in front of me said, I'm taking 1. I said, oh, how often do you take it? It's 10 days. I said, I'm assuming you're taking an antibiotic? He said, yes. I said, are you compliant with it? He said, well, I'm on my shift. I got a lot of things to do. Sometimes I forget. I said, well, patients are on their shift too, and they're taking 5 or 6 medications. Sometimes they forget. But, like I said, it's busy, So I said, so you are non-compliant? And he said, you're right. I won't use that term anymore. So I said, how many more days do you have? 3. So you got 6 pills to take for 3 days. Please be compliant, I would assume. Okay, thank you. And so... so which of the following interventions we would like to simplest to implement in a clinical setting? Perception, reality, elimination of the word non-compliance, understanding the role of patient fears, and assessing whether the role of religion influences a patient's decision. Cultural competence should apply to all race groups, non-English and English-speaking, and English-speaking population, and one's gender. And to recognize cultural competence is the American-born physicians to foreign-born patients, but also foreign-born physicians to American-born patients. 35% of physicians in this country right now are foreign-born. And cultural competence for American-born physicians to American-born patients who are different than themselves. And we found that out at speaking to a lot of the patients. And the difference is, from my perspective, the patients were included in the solution. And I'm sorry if did I run out? I have time. 1 minute. So just one elderly black patient, and I thought, I was being really nice, and I said, where are you from? And I said, how can I help you? Can I help you? She said, you want to help me? Do something with yourself. Get me out of this bed. Laying in this bed makes me lazy, okay? So I said, oh, okay. Who takes care of you? I take care of myself. I do my own laundry and I do my own purpose. So these are the elderly. And the other patients, I said, where are you from? And I said, ask where are you from? Where are you from? South Carolina. And I'm thinking, when did you come to New York? Did you come to New York for a family event and you got sick, or do you live here? And her statements was, yes, my parents were a step away from slavery and my grandparents were slaves. I said, and I had to get up at the crack of dawn and pick 300 to 500 pounds of cotton. And then I had to walk 10 miles to a segregated school. And I'm thinking, walk 10 miles? We can't even go 5 blocks without calling an Uber, So I said, how did you walk for 10 miles? And her body language changed, and she said, Well, if you want an education, you had to. Like, what part of this don't you get, stupid? That was the bottom. And I said, did you have to walk back? And she said, no, the principal in the horse-drawn carriage took us back. And we had to get back before dark, before the Ku Klux Klan. I said, how old were you? 10 years old. Could you imagine? 10 years old. And then she went on, continued to educate, went to Voorhees College. It's a 2-year black college in South Carolina. I had to look it up. And she came to New York in the 30s and 40s and continued her education and became a dietitian. Her two children, how many people heard of Stuyvesant High School? Her 2 children were 2 of 5 black children to integrate Stuyvesant High School. And they're in our hospital beds and not in the history books. And please, if you're taking care of, quote, and I ask the patients, if you're taking care of an elderly black patient, there are certain things that you really should think about it. If she was your grandmother, how would you want your grandmother to be treated? And and somebody said, well, grandma don't listen to us, But I said, if you're graduating medical school and you come to a system that's toxic towards a particular population, black population, 6 months later, you're going to be toxic as well through no fault of your own. Systems have to change, and to change is the human value. And thank you.